3, 2, 1. We are live now.
Good evening to all the delegates. Today is our virtual fellowship program session 2, and we are joined today by Dr. Sheetal Mohite from our team, Dr. Priyank Patel, Dr. Aditya Kashikar, myself, and Dr. Tausif. Today's topic is lumbar canal stenosis, the next topic in our planning. I'm going to present in brief about lumbar canal stenosis, and we'll continue our discussions, Q&As, and case presentations accordingly. We also have a short video of laminectomy and facetectomy. If we have time, I think we'll be able to show it here. So I guess my screen is visible to you guys?
Yeah, go ahead.
First. So lumbar canal stenosis, very commonly debated question, very commonly debated topic actually all over. It's actually a most common problem in our OPDs. One of the most common reasons for operative interventions in spine. It has a variable presentation. It is associated with many diseases, and that's why has a varied prognosis. And unfortunately, this doesn't have a one treatment fits all scenario. So it is important to understand the basics of lumbar canal stenosis. Myself, Dr. Harshal, and I'm going to take you through the topic in brief. Our learning objectives are brief overview of LCS, various treatment options, and dilemmas in decision making. Lumbar canal stenosis was a term coined by Verbius, and that's why it's also called as Verbius syndrome. Stenosis itself means narrowing, and a spinal stenosis is actually narrowing of a neural foramen, lateral recess, and or spinal canal. But for us clinicians, lumbar canal stenosis is a clinical syndrome. It comprises of low back pain and gluteal pain, bilateral lower limb pain, tingling, numbness, or weakness, with or without bowel and bladder dysfunction or sphincter dysfunction. The most classical presentation includes neurogenic claudication, which we'll go through. There are other definitions, which are radiological definitions, but they are predominantly more for academic purposes than clinical purposes. But what gets narrowed? Last time, Dr. Aditya had shown us a brief understanding of anatomy, where we have a central canal, lateral recess, a foraminal zone, and an extraforaminal zone. So there are two basic aspects. There's a central canal which gets narrowed. Predominantly, it is developmentally narrow in primary and congenital stenosis, and a lateral recess which gets narrowed, causing neural compression. It is predominantly there in acquired and degenerative cases. What causes the narrowing? Who are the culprits? So herniated discs, thickened ligaments, bony overgrowth, facet joint arthrosis, hypertrophy, and osteophytes, and ensuing instability worsens this narrowing. So these are the common culprits, and then you can see in this axial cut, we can see there's a central canal which is narrowed because of a thickened ligamentum flavum, a facet joint, and also the compression in the lateral recess by the facet, as well as contributions from the disc. Kirkcaldy-Willis in 1970s described this three-joint complex degeneration, which holds true today also for this degenerative phenomena. There's a dysfunction in three joints, that is namely two facet joints and disc joint, which leads to a cascade of events leading to instability and a auto-stabilization or a stabilizing event by body, but at the cost of space available for neural structures. And that commonly leads to stenosis. I think you are all aware of this cascade, so I'll not go into the details of it. But yellow ligament, the main culprit, which has been described in many papers after that, after and before of that Kirkcaldy-Willis literature. So yellow ligament or ligamentum flavum is 80% elastin and 20% collagen in a normal yellow ligament. But as the degeneration starts, it leads to various morphological and biochemical changes. In this paper or in this slide, you can see all these changes. The main changes are fibrosis, change in the elastin to collagen conversion, chondroid metaplasia, septal formation, cleft formation, and cystic degeneration also happens. And this leads to thickening of yellow ligament or a ligamentum flavum. We must understand as clinicians the extent and anatomy of yellow ligament. As a surgeon, for me, surgical anatomy involves a superficial layer and deep layer. The superficial layer is attached to the inferior lamina at the superior aspect, and it undermines the superior lamina and it attaches there. But the deep yellow ligament or ligamentum flavum deep layer actually extends to the inferior lateral aspect of the pedicle, and that clearance is very important to clear the lateral recesses. So we'll know it as we go forward. The other aspect is facet joint. Normally, it's a diarthroidal joint and allows axial loading, and it prevents the segmental movements. But as degeneration ensues, all this cascade of events, degenerative events happen. There are a lot of changes happen in the facet joint, predominantly space narrowing, osteophyte formations, hypertrophy, cyst formation, vacuum phenomena, and all this, which leads to narrowing of the lateral recess and the foraminal zone. It is important to understand tropism. We'll know it in the further slides also, because tropism has been purported as one of the pathogenic causes for the degenerative causes in the lumbar spine. Various CT and MRI based classifications have been purported, but I don't think any of them are clinically relevant as much, or they don't. I don't think they're as much used for decision making in the spine. Spinal canal morphometry also is important, because normally we have a round or ovoid canal, but in developmentally narrow canal or primary LCS, we have a trefoil canal. That is because of the shorter pedicles, narrower pedicles, and some morphometric changes in the vertebral body. Typically, these are multi-level problems, and most common involvement is at L4-5 again. And in this, we must understand even a small disc or a small space occupying lesion can lead to symptomatic lumbar canal stenosis. So that is why it is important to understand the radiology and then take a decision accordingly. What happens when canal gets narrowed? So there's a bony compression which happens in primary LCS or developmentally narrow canal, and there's a soft tissue component which is predominantly there in the degenerative pathology, but bony component also happens in degeneration, which leads to strangulation of nerve roots. And this leads to multiple mechanical and vascular events in the nerve root that leads to the classical phenomena of neurogenic claudication. Pathomechanics, as we discussed just now, there are three aspects to it. One is mechanical compression of the nerve roots in the cauda equina, the vascular events which happen because of the compression, and chemical events. So the toxins which are accumulated leads to the classical leg pain in the lumbar canal stenosis. There are many such theories, but nothing has been significantly proven. But for us, the important part is that it is a clinical syndrome. Patient have mix and match of these symptoms: back pain, gluteal pain, bilateral leg pain, and variable neurology. Neurogenic claudication. Yeah.
Can I ask a question in between, or should I wait till the end?
You can ask anytime. Please stop me and ask me anytime. Yeah.
Sir, I was just wondering, when you say that there is a venous stoppage, but an arterial flow continues. So I was wondering how this thing happens at the level of pathoanatomy.
So we all know that venous systems are smaller, first of all, and they have thicker media. So definitely arterial blockage also happens, but venous predominantly, because if there's a continuous compression, what happens when we walk, the demands by the roots is increased for the vascular supply, and the first thing that gets compressed is the venous structures, and that's why neurogenic claudication happens at that time.
Thank you, sir.
Yeah. So normally we must understand and differentiate between neurogenic and vascular claudication, because it is going to be the important determinant for us when we plan our treatment. Usually the symptoms are progressive. Patient eventually decompensate, and that is the time when they come to you. Lumbar canal stenosis classical presentation is more symptoms and less signs. But couple of signs, that is gait is important. The patient appears to be crouched. There's a slow and cautious gait. Shopping cart sign or forward bending sign is always more often than not positive. Neurodeficits will be present, will be seen as and when they're present. Treadmill test can be done, but it is not typically done for our diagnosis, because diagnosis is more apparent. We must differentiate, as I'll again tell you, between neurogenic claudication and vascular claudication, because neurogenic claudication has some specific symptoms. They have dermatable distribution of pain. They have associated neurological symptoms. They do get better when you sit or lie down. And typically, when you stop, you can again walk. But vascular claudication is non-dermatomal. Peripheral pulses are absent. They're relieved by standing also. And again, trophic changes in the skin will be present. There are some scenarios which commonly present, like classical presentation will always not be there, and LCS person may present with a severe radicular pain, and we should know when there is a SLR positive, what can be the associated cause. So the two most common causes when there is a radicular pain is LCS with disc prolapse, acute and chronic presentation, or LCS with facet cyst. Sometimes there's a significant back pain, and the two again main causes for back pain, one is listhesis or instability, and the other one is a fracture, because these patients are typically 5th, 6th, or 7th decade of their life, and a significant osteoporosis is always there. Bladder disturbances, again, as I told you, 6th or 7th decade, when there's a bladder disturbance, make sure that you rule out other obstructive causes or other urinary causes before putting this on a neurogenic bladder. So that is very important. Anterior thigh pain. More often than not, you will find patients with multi-level LCS and an anterior thigh pain. Important to know that you should look for a high disc, look for a high level LCS, far lateral discs at lower levels, some neuralgia kind of phenomena, peripheral neuropathies, and also hip joint pathologies. Certain etiologies which stimulate LCS, so these are all red herring signs. Always look out for hip and sacroiliac joint, always assess them. It's important to find and always suspect infections, tumors, and fractures, because these are also common in these age groups. There are certain variations of leg symptoms, and these are not good signs. These are all, again, red flags. If you have imbalance, if you have rest pain, if you have numbness without pain, or neurology without pain, there's a radiculopathy but not true claudication, or significant neurodeficits. So always look for the associated causes, look for some any medical causes, because these can be present. So always remember these red herrings, to keep this in mind: knee arthritis, SI joint pathologies, hip arthritis, Parkinson's or extrapyramidal syndromes, neuropathies can be diabetic, other medical neuropathies, and peripheral vascular diseases. So when a straightforward LCS comes to you, look for knee OA and vesting and tremors, check for pulsation, reflexes, and neurology, ask for bladder symptoms and leg symptoms at rest, and discuss the exact problem, discuss what is the expectation, discuss what he exactly wants out of it. And then you'll be able to with this you'll be able to rule out maximum red flags. LCS has been classified in multiple different ways. Anatomical is the one where central and lateral recess, foraminal, and extraforaminal. There's an etiopathological classification, which is classically described as congenital and acquired. Our discussion largely holds with acquired and degenerative causes. But for me, the most important classification is a clinical classification. A simple LCS and a complex LCS, because that determines my decision making. A complex LCS is the one which is associated with other pathologies like listhesis, region scoliosis, tandem stenosis, revision or adjacent segment diseases, or associated issues like ONE. MRI-based classification have been proposed. They're the most common being Lee and Shizaz. This basically depends on a footprint of a dural sac on an MRI and the lateral recess. But
20 minutes. So what will be 20 minutes to 5?
Here, this is also of academic value and less of this doesn't affect my decision making, but I'll be happy to hear some other views if there are any from our panel. Natural history of disease also important, because these are 6th, 7th, and 5th decade kind of people who have lot of comorbidities, lot of other issues. So decision making becomes important. So clinical progression of this disease is always variable. It has multiple factors and demands. It is multifactorial, depends upon patient's demands and lifestyle. Largely it is said that 60% remains status quo, 20% improve, and 20% deteriorate. Radiological progression is always a rule, is what is said in multiple papers.
सर प्लीज
but that
किसी
may
का
not be-
माइक बीच में चालू हो जाता है तो उसको जरा बोलो कि माइक
Harshal,
बंद करें.
just wait.
Yeah, please.
Can Ortho TV mute all candidates other than Harshal?
I think we're sorted. I'll stop again when the mic is on. So radiological progression has been reported that it continues, but it is not clinically relevant or clinically significant. And role of non-surgical as well as surgical interventions on natural history has also been a dilemma. You can see multiple papers. So Johnson studied for 4 years of their non-operative or conserved LCS. They found 70% remained status quo, 50% improved, 15% improved, and 15% deteriorated. Again, main lumbar study or Finnish group or sport trial or NAS guidelines, more or less they all say that long-term outcome of a non-operative and operative lumbar canal stenosis, all parameters improve in both the groups, but surgical outcomes are better. And there were no catastrophic neurological deteriorations which were noted, though I may put a star mark on that, because in recently I have operated a couple of guys who had sudden cauda equina and I had to kind of do them in emergency, but largely you don't find that or the percentage is less than 2%. What is a conservative management? After understanding the pathophysiology, etiologenesis, and the classification, conservative management largely rests on activity modification, lifestyle modifications. You teach them to remain in their confines, start working on the multimodal physical therapy. Though there's going to be a couple of slides which are again, you're going to ask so many questions. The role of pharmacotherapy or bracing is not as relevant, and guidelines have said that they have very low evidence to propose pharmacotherapy or bracing. But at the end of the day, a lot of us have our own protocols, and we should actually go by our evidence and anecdotal experiences, as well as our own patient outcomes, patient-reported outcomes, and devise our own conservative protocol. The role of pain management is also something which we're going to discuss in the couple of slides. What is the role of surgery in lumbar canal stenosis? So largely, most of the trials have reported that the surgical outcome in LCS is much better. But a long-term outcome in all the studies have shown that at the end of the day, there's no clinical significance between two. But treatment has to be individualized. The principle of surgery is neural decompression and stabilization in an unstable spine. The options of surgery or options of decompression are two: direct and indirect. Direct are usually open wide decompressions or MIS decompression or endoscopic decompression. They involve laminectomy, foraminotomy, multiple medial fascectomy, or interlaminar decompressions. And indirect are typically proposed when there's a foraminal narrowing, the ligamentum flavum infolding, and instability related neural symptoms. So we'll have the discussion on that also. Direct decompressions typically have expansile or less invasive approaches nowadays. It actually addresses the pathology and the components of stenosis. So we are actually supposed to see the nerve root decompress in front of our eyes. It can be a direct decompression by a wide laminectomy, or it can be over-the-top decompression by a unilateral laminotomy. And all these other approaches which have been described, like spinous fasciostomy or spinous fascia splitting and all other, or tubular, even for that matter, tubular decompressions, are all the variations of the approach. The principle of treatment remains the same. You have to adequately decompress the neural structures. What is laminectomy and what is medial fascectomy? If you see in this axial cut, we have a central canal stenosis and a lateral recess stenosis. When you do a laminectomy, you are actually decompressing the central canal. When you remove laminectomy and the medial ligamentum flavum, the midline ligamentum flavum, you are decompressing the central canal. So you have enough play there, but the lateral recess still look to be tight. We actually have to cut the facet, or we have to kind of, if it is overhanging, but we have to kind of get the lateral recesses cleared, and that actually gives us a wide, nice root which is seen here, and that is the proper medial fascectomy which is required for a lateral recess stenosis.
Dr. Harjot.
Facet, yeah.
Sir, can you again read the first MRI?
Yeah, tell me.
Sir, can you read it, sir? I am unable to gather whatever you have said, sir. So
I'll tell you, I think, can you see my cursor?
Yes, sir.
Yeah. So this is a central canal. You can see there's a ligamentum flavum hypertrophy, right?
Right.
Yeah, the canal doesn't look to be wide enough or ovoid enough. So there's some amount of moderate to severe stenosis here. The lateral recesses are not well seen, though this is a representative cut. But the roots in the lateral recesses are not very nicely seen, or subarticular and foraminal component is not that well seen, and that is what we meant by this. Yeah?
Right, sir. Right, sir.
Yes. Again, facet alignment in lumbar stenosis is also important. sagittal and coronal facets. So normally we have 45-degree sagittal angulation of the lumbar facets. If they are even more sagittal, then that is something which we associate with progression of degeneration in the lumbar canal stenosis. You can see this is a sagittal angulation. This is slightly a coronal angulation. If it is more than 45-degree angulation, sorry, this is wrongly mentioned here. It is 2.5 times more likely to develop, not 25 times, 2.5 times more likely to develop degenerative listhesis, most commonly at 4 and 5. The buttressing effect, if you see the anterior overhang of the facet, that actually prevents the movement, or that actually prevents the segmental mobility when you have a little more sagittal orientation. And when we do decompression, if we take out this to decompress the lateral recess, we are actually inviting for instability. So remember, when you're planning your surgery, and if you're going to do this, you might need to do stabilization. So this is one of the indications to do fusion in lumbar spine. So this can happen, and you can create an instability. If it is more coronally angulated, then actually we can do decompression without destabilizing the facets. Posterior decompression, medial fascectomy. If you see the first image on the right side, upper column, you can see two kissing facets very close to each other. And you cannot adequately decompress by just doing a midline decompression. You have to go nice lateral release. Yeah.
Sir,
Any
could not
question?
hear you.
Yeah.
Could not hear you. You broke up,
Yeah.
sir.
No problem, no problem. I'll repeat it again. So the first picture on the upper column, you can see there is a upper row. You can see that there's a facetal kissing facets, very closely set facets, and you need to kind of decompress the cut. Do you know? To get a nice root decompression, you have to cut that facet. But while doing that, we are sometimes inviting for a bigger devil, that is a total fascectomy. That accidental total fascectomy, though it is literature says that one side, even if you remove a complete facet, it may not destabilize, but we should tend to avoid it. And once you do a nice lateral fascectomy, you can see the root on the lower, the last image. Just the silhouette of the root can be seen. So fascectomy makes an important, like that is the difference between us doing a nice wide decompression when we're doing all this open kind of surgeries. Medial fascectomy, nerve root can be adequately decompressed. What is the extent of lateral decompression? That is what all those slides were about. So you should always look for the landmark, which is pars interarticularis, and we should always preserve more than 5 mm of pars interarticularis. I would say up to 7 mm to 10 mm, but at least 5 mm of pars interarticularis should be preserved, because we don't want to, when we burr or when we osteotomize, we don't want to cause an iatrogenic pars defect or iatrogenic pars or iatrogenic instability. When do you supplement discectomy in LCS? So again, both the things are important, clinical as well as radiological. When you have an asymmetric leg pain, a proper radicular kind of a symptom, acute on chronic presentation, or one-sided deficits, you should always look in your radiology that do you find any soft disc there. Largely hard disc, and if I'm doing only decompression, I might not address if I don't find that root is not adequately decompressed. So there are a couple of examples when discectomy was required in an LCS. What are the indirect decompression? So the principle remains restoration of disc height, restoration of foraminal height, and ligamentotaxis kind of a phenomena, and realignment of unstable segments. So there are a lot of literature available. These are not my cases. They're from the literature. What are the advantages of indirect decompression? They can be done by O leaf, X leaves, A leaves, MIS, T leaves, where you actually are not touching the pathology directly. You are just trying to recreate the space there or recreate the area available for the neural structures. They avoid direct neural handling and associated complications like neuralgic symptoms, dural tears, and all. You can actually have a better sagittal balance. In today's lecture, we are not actually talking about 3 or 4 things, one of them being sagittal balance, because that is going to come in the next few lectures. And these actually are purported to increase the area available for the neural structures. There are some wonderfully illustrated cases here where they have actually proven on radiology. They have actually restored the disc height. They have created the space for the neural canal, but it depends on person to person. So decision making should be depending upon your expertise. So what are the dilemmas? There are always diagnostic dilemmas. What should be our ideal conservative protocol? When should we use pain management in LCS? And in complex LCSs, what should be the decision making? So I'll just go ahead with the first case, and then we'll ask for, this is my algorithm typically. Degenerative cases, I typically conserve when there's no major neural compression, but there's a symptomatic patient. But when there's a neural compression, patient is compensated, I will conserve. When it is decompensated, I will talk to him, I'll find his expectations. If I'm able to fulfill them, I'll offer him a surgery. If not, I'll conserve him. And that is where sometimes pain management comes in. And when there's a neural dysfunction, which is acute, I might offer him a surgery. And it is chronic, again, the same principle, expectation settings, conservative versus surgical treatment. But the major determinants remain age, comorbidities, stability, pathology, affordability of the patient. I can't offer a poor patient expensive MIS tele for endoscopic surgery. Access to healthcare and expertise in my hand. Any questions?
Sir?
Yeah.
Yeah. So, like it is popularly said that the LCS is always like a decompensation between passage and passenger. So, in our house, what do you mean by adequate decompression? So, because there is no specific definitions for LCS per se, so the definition of adequate decompression person to person, it varies. So in like general scenario, what should be the adequate decompression?
My lad, my answer would be what surgeon feels adequate. Because it's patient reported outcomes. You will know when your patient is coming back to you when you have done incomplete decompression. So you'll learn that by experience. But I would say adequate decompression is when you can see the spill out of the root, which is free. There's enough mobility for the root laterally and medially. And you can actually, I tend to probe the foraminal region just to see if my probe or my dura is going in the foramen. And that's my adequate decompression. But when I do a decompression, I also look at the proximal and distal level, because in a lordotic spine, there's a dural fallback also. There can be a relative stenosis above and below. So when predominantly I come from a unit which is largely an open laminectomies, we do a lot of MISs, but we would love to see a complete neural decompression. So for me, adequate decompression in lateral recess is where the mobility of the nerve root is checked. And I can feel the foramen, and I can see that there's no other, my probe is going easily. Tosi, that answers your question, or you want to ask something else?
Yeah. Thank you very much.
Perfect.
Sir, one question.
Yeah, please.
It is seen in the spondylolisthesis cases that the patient do not get the neurological symptoms. Mainly they have back pain, and sometimes they are having pain while they are standing position. So what is your thought process? Is the spondylolisthesis grade 1, or sometimes grade 2 is the natural process of decompression, which causes do not cause any neurological symptoms?
So every time the nerve root will get irritated, it will be a biological issue. Until then, it is a mechanical issue, and the mechanical issue will be presented by back pain. Sheetal, sir, any thought?
Harjot, can you switch off the screen sharing while discussion? We can. Okay,
Perfect. Yeah.
Can I just quickly?
Better.
I think Virendra, you were asking it out, right?
Yeah.
Yes, sir.
Yeah. So see, basically what you just mentioned, that in a spondylolisthesis patient, there is an auto decompression that actually is not the right thing. See, there are two types of listhesis here that we have. One is a degenerative listhesis, and the other one is a lytic listhesis. So if you're looking from the top part, you have one canal of, let's say, L5 vertebrae, and you have one at L4. So when there is an anterolisthesis, the L4 will go above, will slide anteriorly, and that will in fact cause significant central canal stenosis. In a lytic listhesis patient, you will have a auto decompression of a central canal because the posterior element is going to be lying back. But in that case, the problem does not lie with the central stenosis, it's more with the foraminal stenosis. The history that you gave, that when these patients, they don't really complain of claudication, but after standing for some time, they start complaining of back pain. Now, here sometimes it is the patient are not aware about the history. But if you actually probe inside and you explain to them what they are supposed to feel, almost always they'll say that after standing for some time, they might not be feeling anything in the legs, but they will definitely tell you that they start feeling cramping sensations in the lower back. They feel paraspinal spasm. Their family or relative will say that they have started crouching when they stand and walk. So although typically this is not a neurological claudication, but you can associate this and call it something like a back claudication.
Back claudication.
When patient is not feeling the leg symptoms, but all the symptoms are there.
True.
So
true,
I would like to make one
Yeah,
comment over here.
Yeah, Aditya.
Yeah. So I would like to make comment of what Priyank said just now, that if at all patient is not aware about his symptoms in terms of leg symptoms, so if we have to just make them aware that they have that actually, because on history examination, if we see that there are a few telltale signs of LCS on history and examination wise also, but patient is denying that fact that there are no leg symptoms, then in such patients, you can ask for a treadmill test.
Yeah.
So this is typical indication where you can ask for a treadmill test, so that and you can tell them that what all things you have to look for at the time of treadmill. So,
but I will take a different
indication for a treadmill test, which we usually don't ask.
Yeah. Rightly so. But I'll take a different view, because he had asked a very different question altogether. He had asked that when you have a degenerative listhesis, grade 1 or grade 2, patient have only back pain and no leg pain. And why so? I think, Virendra, that was your question, right?
Yes, sir.
Yeah. So, but we have actually covered that other topic also of lytic listhesis, which is very good for all of us. But as I was telling you, that if there's a neural involvement, then there are biological issues which can lead to nerve inflammation and leg pain, or mechanical compression of nerve and leg pain. But when there is only structural problem or mechanical instability, that would largely present as a back pain. Yeah. Perfect. Any other questions? I'll share my screen again once.
Sir?
Yeah, bolo na.
Sir, I was wondering, sir, again, sir, when it comes to that Crikaldi-Willis theory, sir, the tunica media of artery is thicker than the tunica media of vein.
Yeah.
So then the pressure should. I think I will try to paraphrase what you said.
Yeah, I'll tell you one more thing. These are all theories proposed and nothing is proven.
Okay.
Yeah, we talk about neurogenic claudication symptom because I also wondered when I was studying it, why neurogenic claudication? Why it is not always present? Why it comes only when we walk for 100 steps or 200 steps, or why it happens so?
Right.
But patients' histories will be like that only. So these are all theories proposed, that there's a vascular insult, there's a mechanical insult, there's a chemical insult, but nothing is proven as such. That is how it presents. But largely this stands true that when you walk a lot, the demands by roots is more. They want nutrition. Because there's a blockage, the nutrition doesn't reach, and all these things ensue that way.
Sir, another thing that comes to my mind is, sir, जो Burgers है, Burgers is true claudication. और ये जो हमारा LCS है, this is pseudo claudication. लेकिन pseudo claudication के अंदर में भी actually vascular component ही है, जो कि
नर्व में हो रहा है,
कुछ कर रहा है,
नर्व में हो रहा है टाइप, ऐसे
नर्व में हो रहा है टाइप. Got it, sir?
Perfect. चलेगा. So dilemmas in LCS is the anyone please. Someone was saying something? Yeah. So I'm going to start with two scenarios. These are not actually proper case presentations, but directly jump here. So this is an 85-year-old.
Can I say
Yeah,
something?
please ask.
If you have a case where you're seeing a lot of spondylosis and the patient is only complaining possibly facet arthropathy from all the way from T12 all the way to L5S1, but his symptoms are only neurological claudication and you find you have L4, L5 stenosis. Would you go in and treat everything or you just go in and do a laminectomy only?
So a very nice question,
Only.
and these are very common scenarios actually. And I think one of those scenarios will be presented either by me or Tausif. We both have that case ready. But to answer you right now, there are two philosophies. I belong to a very different philosophy. I would actually put my foot on my clinical examination. If my clinical examination is very specific that L5S1 dermatomes are only affected, then I would do only that amount of interlaminar minimally invasive decompression. But my determinants are so many. My determinants are age, comorbidities, kind of weight. Weight is also a comorbidity, instability, and all those things. And then I will take a decision. Sometimes access to the facilities also. Mumbai, my patient can come to me multiple times. But at a patient coming from a very small village, I might think of getting everything sorted for him because he cannot afford to come every now and then that way. So it's not a MRI based or an X-ray based decision. It's a person around the MRI, and that actually makes my decision. But I would largely say I'll back my clinical decision, my clinical assessment. And if I see in a young office-going chap multi-level issues, but only L4-L5 is symptomatic and severely stenotic compared to the other, I might only do L4-L5. But I think Sheetal sir, you would want a different opinion. Your mic is muted, sir.
So I agree with you, Arjun. You put it across very beautifully. It's more need-based and that kind of a decision in which you can take a call based on making a consented decision than the scenario you are saying about. But as a philosophy, we try to decompress. It's D12 to S1 would be a really long decompression. But as a philosophy, we try to make it like one-time go. But I completely agree with this other thought also that you said, that if it's going to be a scenario in which a complete access is not going to be possible every time, then maybe one time go is good. Maybe if it is good enough in such scenarios in which repeated assessments are possible and it's a consented decision, then have a repeat some stage later. You do not know how long that person may be able to on, because radiological stenosis does present earlier, much earlier than your clinical presentation. So this also is a valid decision. But as a teaching, if you ask me, I would be happier to do a long segment decompression. We believe that it's like making it as a one-time go, and something significant proximally should not be left behind to explain some distal symptoms. Put it across in that way.
True.
One additional objective way of looking at level planning, what you could do is once you have all the other factors into picture, radiologically you can look at the axial cuts, and at every level where you see a sagittal stenosis, you independently view each and every level and think in your head that does that level, just independently, if that patient would have come with that stenosis on the MRI, would you decompress? So if the answer is yes, then in your surgery, you should include that level. But if the answer is no, that, okay, this is a very mild or moderate stenosis and you might not decompress if it's an independent entity, then in a younger patient, you can leave it. And in an older patient where you get just one chance, take care of that as well. So that's the way you can levels.
So
Aditya, I might rephrase this question. Aditya, I might ask you a more straightforward question. The same scenario, a symptomatic LCS, D12 to S1, everything is radiologically stenotic, but in which cases you would not decompress everything?
So you are asking me, Harshal?
Yeah. Just for the sake of audience, I'm asking you that there's a symptomatic L4, L5, but D12 to S1 is radiological stenotic. Which cases you would refrain from doing a multi-level surgery?
So multi-level surgery, if at all, it's only the stenosis. See, there are, I think it has to be a case-to-case basis decision rather than having a fixed ideas about that. That there are multiple factors like how much is the back pain? Is there any instability radiologically present on higher levels? Though those instabilities may not be reflected in terms of symptoms, maybe. So symptomatically, if only L4-5 is symptomatic and stenotic, then only L4-5 doing makes sense. But again, I think we have to be open-minded in such scenarios rather than having fixed ideas. I usually don't go by any fixed ideas. Patient's symptoms are utmost important, and plus radiological details. Whatever earlier three speakers have told, I think everyone is trying to make one point that judge the case to case
It is an
basis.
individualized decision. Yeah. Very
Individualize
true.
it. So rather than having
I'll just add
fixed thumb rule that.
Yes, sir.
Yeah, no. Aditya, continue. Sorry.
Yeah. So rather than having any fixed ideas about what we have told, there is nothing like thumb rule in spine. Let me tell you, everything can be considered and everything can be operated. Okay.
So that was my first slide. That one treatment fits all is not possible in LCS.
Exactly. So rather than having fixed mindset about dealing with LCS cases, keep your mind open, give more important to patient symptoms, your clinical examination, and then come to radiology and correlate your symptoms and earlier assessment with the radiology, and then plan out your what all levels you want to do.
Perfect. Yeah. Any other questions?
Only one point in addition to whatever you all have discussed. I feel developmentally narrow canal, if it is clearly documented, then it goes much more in favor of doing a longer segment decompression. I think so. This one we should, and usually developmental narrow canals are like L1 to S1 types decompression. So
true.
With a well documented developmentally narrow canal.
Yeah. Sorry.
Yeah. Agree. Yeah. You can go on.
And one scenario where I won't be doing long segment decompression, for example, if patient is medically unfit and I have to get rid of or rather I have to reduce the surgical time. And in my mind, I'm clear that the symptomatic level is only one level L4-5. Then maybe I'll just try to do it as quickly as possible, just decompress L4-5 and come out.
Point well taken.
And I can explain patient that, okay, these things are there. So before surgery only, I'll be explaining this to patient that there is stenosis higher up also, but in view of its high risk condition because of medical conditions, we have to reduce the surgical time.
So as Dr. Mohit had already told earlier that consented decision is more important. When you understand, you explain them everything. But I'm doing only symptomatic level. The other levels can become symptomatic later on. Rightly said, Aditya. Perfect. So, any other questions? Any other questions from delegates?
Sir.
Yeah. Please carry on.
I would like to paraphrase whatever message has been delivered right now. So, sir, if 50-year-old male presents with anterior thigh pain, and there is no other clinical neurosensory motor vascular deficit, the clinical suspicion remains an L1, L2 kind of neural canal, lumbar canal stenosis. And if MRI shows L1, L2 to L5, S1 kind of, disease, this requires decompression only at L1, L2. Sir, did I get it correct?
You have actually generalized all the statements. No. Let's see. Right now, this is a group where you have to go back with a take-home message. You have just presented a patient who is 50-year-old, who has got anterior thigh pain and who has got a 2 to L2 to L5 significant compression on an MRI. If the MRI is significant compression, which means if you see the axial cut at 2-3, there is compression, 3-4, there is compression, 4-5, there is compression. You know that eventually the patient is going to require surgery at 3-4 and 4-5. You do a L2 to L5 decompression because the patient that's the policy, that's the take-home message you have to go with.
Thank you, sir.
Yeah, great.
Thank you, sir.
Perfect. So not everything can be generalized, but we're talking in general about decision making. And as very rightly said by Dr. Priyank, that you cannot take this home and like take this message out that you should not do it. But I think if there's a clinical radiological mismatch, then take a decision accordingly. So this is an 85-year-old gentleman with chronic low back pain, bilateral leg pain and paresthesias, unable to walk 10 steps since last 3 months, a history of occasional fall. There's significant burning in bilateral feet. He's a hypertensive, diabetic, smoker, all those things come with. Gait is supported and broad-based. Power is like there's no motor deficit, and sensation is reduced bilaterally in leg and foot, non-domatomal. And this is the MRI he comes to you. Anyone would want to take this up? What they would do next? Tausif, what would you do?
So this gentleman who is 85 years old and has came with symptoms of unable to walk. He is the MRI shows the stenosis at the level of L4-5. But again, like burning in the feet and non-dermatomal distribution, it again points to me towards some of the peripheral neuropathy, and I would like to rule out it first since he is diabetic. So, which is one more pointers towards diabetic neuropathy.
Perfect. So, right
So,
now,
Tausif, are we okay to just plan based on this, or any other test you would want to do based on what you just said?
I would again go for EMG NCV with SSEPs. Most probably, it will show especially sensory delays. Pardon?
No,
you carry on.
कहाँ है?
Yeah.
नीचे
So,
क्या ये?
Authority, can you mute the other guys? Please carry on, Tausif.
Yeah. So it will show delays in SSEPs basically. But I would again like to have EMG NC with SSEPs for this guy.
So does that influence your decision? The investigation, where do you advise it in all patients? What are your indications for doing that test?
So indication for this is usually clinical radiological mismatch, I would say. Considering this case, he has bilateral lower limb paresthesia, history of occasional falls, and the gait being broad-based, it not supports the radiological picture which we have shown. So I would for sure get EMG NCV done and get neurologist in picture.
Perfect. So we have done EMG NCV or nerve conduction studies, and there's a severe peripheral neuropathy. Now, will it, Dr. Priyank, will it affect your decision making now?
Not really. In any of the cases, EMG, NCV, SSEP, all the neurophysiological tests, they are basically more for documentation purposes. They are more for prognosticating the results of your surgery. And in certain situations, it will want you to look deeper. So, for example, in this case, the nerve conduction study is telling you that there is severe peripheral neuropathy. You have a patient with an MRI which is showing a significant stenosis at L4-5 because of a degenerative listhesis. And if you see in the lower dorsal spine, there is ossification of the yellow ligament. Now, basically, with the history that is given here, there is a little bit of clinico-radiological mismatch, like what the Tausif just pointed out, that a patient with a simple LCS should not usually walk with a broad-based gaze. When a patient has a broad-based gait, you want to either rule out a sensory neuropathy or you would want to rule out a myelopathy. So EMG, NCV, SSCP here will tell me if that dorsal stenosis is significant. Because if there is delayed SSCP, then you would want to get a detailed dorsal spine MRI done to see if that level is stenotic. A peripheral neuropathy, when a patient is presenting with, it helps us counsel the patient that eventually after the surgery, his claudication is going to get better, but he will have residual sensory symptoms in the legs. So that is basically what your all these neurophysiological studies are going to help you out with.
Perfectly, very rightly mentioned. So there was a diagnostic dilemma: is what is the cause? Definitely, we should. It should not affect directly in such scenarios where it's proven on a radiological study that there's significant nerve compression and there are matching symptoms, but there's one more add-on diagnosis. So you should be able to prognosticate, as very rightly said by Sir. Why it is important to know the diagnoses? There are many differentials. There may be vascular, neuropathic, epidural lipomatosis one, space occupying lesion is the other. Yeah, please carry on.
Sorry, just before we progress, there's just one point regarding peripheral neuropathy. Now, your last case basically had a patient which is proven to have significant peripheral neuropathy. Is there a way by which you can kind of assess how much the patient is going to get better after the surgery? Like, is there any way by which you can explain to the patient what difference they're going to find out?
I think I would want this by delegates to answer this question than me. But delegates, anyone want to answer this question by Dr. Priyank? That is there any way in this present case to clinically assess how much of benefit he will get after the surgery?
So just quickly, a very important clinical way is you ask the patient to feel or describe the symptoms that they feel when they are lying down. They will have some symptoms that are there, which are there at present when they are lying down, and there will be few symptoms which will present itself when they are walking, or there will be few symptoms which will increase when they are walking from their lying down position. So when you do a decompression surgery in a patient where there is pre-existing peripheral neuropathy and claudication, the very good way of telling the patient is all the symptoms that they feel after standing up will go away after the surgery, and the ones that they feel while lying down will most likely remain.
Perfect.
So
yeah, one more
with the diagnosis.
Dr. Priyank.
Yeah.
Sir, what you said, it means that the feature that you feel while lying down are due to peripheral neuropathy, and the feature due to standing and walking is because of LCS. So LCS to ठीक हो जाएगा, peripheral neuropathy रह जाएगा.
Correct.
Okay.
It is very broad. It is very broad assessment, but this is what will tell the patient what will remain and what will go, kind of. Yeah.
Because the most important thing that determines the result of the surgery is setting a very good expectation before the surgery. तो patient को अगर आपने बोल दिया that सोते सोते जो symptoms है वो रहेंगे, but चलने के टाइम जो बढ़ रहे हैं वो कम हो जाएंगे, that helps the patient understand what they should expect after the surgery. So the post-surgical outcomes will definitely improve.
Thank you, sir.
So largely these patients are kind of high-risk patients. So we should be able to plan our intervention and prognosticate well. So we should kind of be aware of our if there's any misdiagnosis, what symptoms will persist, where we should give guarded prognosis, and where poor outcomes are expected. So there's a lot of literature about these things, LCS and red herrings. So that's why I wanted to highlight this point before going to surgical kind of scenarios, that diagnosis is the first dilemma. Any pointers by our faculty, Dr. Aditya or Dr. Mohite?
So usually in these chronic cases where tight stenosis are there, old patients, there are few telltale signs on examination which tells me that these patients are probably bad candidates for surgery. One of them is looking at their toes. If you see that their toes are clawed, that means that the patient has a chronic compression. There is significant amount of peripheral neuropathy that is there, and
Trophic changes.
yeah, the outcomes are not are going to be a little guarded. The other thing that you have to also see is in such tight stenosis, you would want to look for a undetected bladder involvement. So these patients, you should get a pre and post void USG done. And if you see that the post void US residual is more than 300, means that there is a pre-existent involvement of the bladder, and there is a chance that after surgery, the patient will go into something called as bladder decompensation, which means that for a couple of weeks, the tone of the bladder is going to be less, and there is a chance that the patient might not have come on a catheter, but will go back on a catheter. So if you see such tight stenosis with clawing of the toes, or the patient is not able to walk on the toes, so toe walking is deficient, then these are telltale signs that you want to guard you have to give a guarded prognosis in this patient.
Sir, the bladder volume for male female is the limit is 300 ml, or does it change?
No, so generally when there is a post void residue which is more than 300, that correlates positively with having a problem in the urodynamic study. So a quick screening for bladder is the post void urine. So if it is more than 300, and if the facilities are available, it is worth doing a urodynamic study, because that is a documentation of your bladder involvement. But if it is not there, a quick screening is this post void residue, and that's common for both male and female both.
Yeah, thank you, sir.
Perfect.
So the symptoms wise, that clawing of toes, what Priyank was talking about, the symptoms wise, these patients will say that there is slippage of chappal while walking, because they are not able to hold chappal properly. So that is indirect way that there is S1 deficit. And what Priyank said, that you have to be watchful in such kind of patients.
Perfect. I'll quickly move on to the second case scenario. A 73-year-old male gentleman, chronic bilateral gluteal pain, 1 week onset of acute left radicular pain, unable to walk even 10 steps, and there's a left more than right foot tingling and numbness. Has all the comorbidities, gait is supported, but there's absolutely no neurodeficit, and comes with this MRI. What will be your plan? Aditya, Dr. Aditya, you want to start the discussion on this? You're muted.
So we have this elderly gentleman with typical symptoms of LCS. And there is, as I can see, L5 is sacralized. So I can see around, I think, last 2 mobile segment LCS. Harshal, can you just take out that plan thing? I want to just see the whole spine screening. Yeah. So I feel that since it's not mentioned here, it doesn't have any
clinically
unstable
normal. Yeah.
neurology normal. Yeah, and
normal. Yeah.
Okay. So there is last 2 mobile segment LCS with which side is more left more than right. Okay. So there is query disc at left L34 level with inferior migration, or maybe facet cyst at that level, which is the cause of left-sided pain more compared to right.
Okay.
And
now patient has all these comorbidities and is unfit or maybe unwilling for any intervention.
Unwilling for intervention. Okay. Okay. So in such scenario, maybe we will have to tell patient that ideally surgery needs to be done. Because there is severe stenosis and it's a mechanical issue rather than anything else. So that needs to be addressed by surgery. But because of unwillingness or because of unfit medical condition, if we have to give any treatment option, then I think pain block will come in picture, pain management in such scenarios. Even though in normal circumstances, such a tight stenosis, I may not advise pain blocks in such tight stenosis. But these are the conditions or scenarios where I would suggest them pain blocks.
I'll just give a disclaimer that he was operated. He was, he underwent a surgery. But just for the sake of creating some controversy, I put this up with a very severe LCS with a disc. So what would you do if he's unfit or unwilling? So dilemma to conserve or to do blocks. But yeah, anything to add?
No, actually, Harshal, this type of scenario comes and presents to us more often
than not. Yeah.
Yeah. So, Sheetal sir, I'm sure you have in your career seen so many such patients. What would you do? The patient is unfit for surgery. This is the MRI. What would be your next step? Sir, your mic is
muted.
On. Yes.
Yeah, got it. So, if there is no deficit and patient is unwilling due to medical reasons, then I would actually put him across through a conservative trial. I usually put such patients through at least a 10 or 2 weeks bed rest protocol, and then try and see if the symptoms get better, because I believe the limbs have now exacerbated because of the disc which has come out. The XCS was always there, and it is the disc which has brought the symptoms up this time. So if this acute neuritis to the disc settles down with whatever medications, anti-inflammatory and anything else, then we hope that as time goes by, he'll get better and better, leg pain wise, the intensity that wise. But if it doesn't get better, then as Aditya said, you could consider a pain block as a next option. So that's how I would in such a case if it is unwilling patient or an unfit patient.
Correct. So this is actually very important, and this is something that we wanted to bring out. So let's get some facts straight. Number one, there is no conservative treatment. You cannot conserve a lumbar canal stenosis. That's a misnomer, because you can conserve a disc. A disc is something that can get better conservatively. So in a lumbar canal stenosis, there is no conservative treatment. But when we mention the word that we are going to conserve this patient, there are a lot of things that are involved in this. One very important is patient counseling. So here you have to tell the patient that you require surgery. Without surgery, the claudication is not going to improve. But we can maintain this and prevent further deterioration by living within our claudication limit, which means if you're able to walk only for 10 minutes, after every 10 minutes, take a mandatory break. That is number one. Number two is you can start with some stability exercises for these patients. And this basically will help a little bit by taking care of the soft stenosis which is there. The third part is you find out the cause for that acute exacerbation. Like this is something that has been going on for years together. Something has happened because of which the patient has come to you with this acute pain. And like what Dr. Mohite just said, that is a small disc which has come out and that is causing radiculitis. Then you start treating this patient for that radiculitis, which means you give bed rest, you give anti-inflammatories, you give oral injectable steroids, all of these different types of options. Or in certain situations where this is not helping, you give a selective nerve root block. Now the discussion comes, is block going to be safe or is it contraindicated? Well, there is no real contraindication for selective nerve root block. But in such tight stenosis, you would not want to give a epidural injection. Because when you give epidural injection, there's a chance that you might develop epidural hematoma. Or in a tight stenosis, you're pushing 1 cc of drug. That itself is big enough to cause sudden acute deficit. So selective nerve root blocks are safe. But the most important thing is counseling. So if the patient has a claudication time of 10 minutes, after a block, after medications, tell them to remain in their claudication time, not exceed it. Like taking the block, if the pain is less, they should not go and walk for an hour, because then they'll land up with sure problems. So that's basically what you all should get in these type of patients where surgery is needed, but you are trying to conserve the patient. These are the points that you have to keep in mind.
Sir, if the claudication time is 10 minutes and if he walks 60 minutes, what will happen, sir?
So what happens is that is where the chances of further neurological deteriorations and all that can happen. So usually 10 minutes to 60 minutes is not possible, but after 10 minutes, what happens is if the pain is not there or they are numbed with all the different types of medications that we give them, they sometimes tend to walk for 30-40 minutes. Now they might be able to do that very day, but the nights are going to be terrible, where they will have a lot of night cramps and radiculitis, and they could wake up next morning with severe back pain and stiffness. So that would happen if the patient walks beyond their claudication limit.
And sir,
Virendra, you wanted to...
Sir, if there is only claudication problem and there is no radiculitis, then there is no role of selective nerve root block. Sir, this statement correct?
No. Yes, it is absolutely correct, because if there is no pain, then the block will not help a lot.
Thank you, sir.
Sir, I
one more
wanted
question.
to ask. Yes, sir. Sir, you have told that in tight canal, we should not give the epidural injection because it will exacerbate the problem. So in which case of canal stenosis do you think the epidural injection will work better?
So technically, in today's day and era, epidural injections are slowly getting into disrepute. Like pain specialists and spine surgeons will not advise for epidural injections. Epidural injections probably are now plan B in places where you don't have a good CM, or where you want to do it in a clinical setting where you are not able to identify the level. That's the case where you would want to do an epidural. Caudal epidural has some role. Multi-level lumbar canal stenosis, where you want to give an epidural, but you are not very specific which single root is the bother. Those are cases where caudal epidural can be given, and it has shown some added benefit as compared to a general epidural, because caudal epidural will not have those risks which are associated with a standard epidural injections which we used to give earlier.
So we should not give epidural injections.
It should be, yes, it should be discouraged.
Yeah.
Hello.
Yeah.
I had a question to Dr. Priyank sir, that as he said that we should be very focusing on the pain blocks or block injection, nerve root blocks for management of one level lumbar canal stenosis. So now my question is how effective are the nerve root blocks in soft tissue lumbar canal stenosis, and in case of any bony lumbar canal stenosis? And as the second question would be, as he said, in caudal blocks are very epidural steroids are very indicated in case of multi-level lumbar canal stenosis. So usually we say that whenever we give a epidural injection, the level of action would be maximum till 2 levels up and 2 levels down. So is that going to work for the rest of the levels above the second or third level?
Yeah, so Shashank, see, basically there are two aspects to it. Now, epidural, the soft stenosis and hard stenosis, the blocks will not directly work because on the stenosis. But when there is soft stenosis or hard stenosis, whichever it is, if that has a added component of radiculitis. So one is a claudication where there is no pain. You're lying down, you're sitting, you're standing, you're comfortable. But after walking for 10 minutes, your leg starts cramping and you have to sit down. This is pure claudication. And in these cases, the blocks are not going to do wonders. But let's say there is cases where the patient says that whenever I'm changing position in bed or getting up and walking, I'm having a sudden sharp pain in the right leg. And then after walking for some time, my leg starts cramping and I have to sit down. Now, this is a situation where there is stenosis in the spine and there is some nerve, one of the nerves which is irritated, or there's radiculitis. That is where your block is going to work. Here you want to identify which level is the block and you give it. Now, if you see, most of your cases of lumbar canal stenosis are going to be 4-5 followed by 5-1 followed by 3-4. So anyways, these compressions are at the lower level. So let's say there is 3-level, you have 3-level moderate stenosis. The patient has got radiculitis, which is bilateral. You are not very sure which specific level you want to give the injection. And you want like the drug to be given fast at multiple levels. That is the only indication for a caudal epidural.
Okay. So because I had one case recently for which I went for like it has a significant disc on L4, L5 level with symptoms more on left hand side as compared to the right hand side. But the other disc was significantly at L1, L2 level. So I went to give a epidural steroid at the level of L3, L4 because as a general principle, the gravitational flow of the medicine would be downwards, and the most significant disc was at L4, L5. And eventually, as we take the rule that 2 levels above, so it will also help for the L1, L2 disc also. But the thing is, like, she came out very happy with the symptoms of L4, L5 disc, but now she's getting a symptoms of anterior thigh pain that L1, L2. So that's what I was worried about. Okay. And maybe I'll think of I'll have to assess her after a few days for the neuritis symptoms, and then I'll take some few steps from this lecture.
Correct.
Perfect.
Thank you.
So I have always discouraged typically caudal epidurals for the want because in severe LCS, there's a significant amount of stenosis and even CSF flow doesn't happen. So I'm not sold to the idea that caudal epidural works as much, but SNRBs are yes. When there's an acute and chronic presentations, there's a proper discal component and a neuritis component to the pain. But you see literature, there are many papers, I'm just quoting a couple of them, and there are a lot of conservative kind of principles that are laid down, but everything is no. There's no recommendation for almost everything what we know as of conservative treatment. Everything recommends against the use of pharmacotherapies, as Dr. Priyank rightly said. There's no conservative management for LCS. So no pregabalins, no muscle relaxants, no epidural injections. There's very good quality evidence against it, and I don't know. That's why I said in the beginning that you plan your own conservative protocol depending upon your experiences. And same, there are a lot of literature and recommendations from Danish studies and World Federation of Neurosurgical. They've also mentioned that there's no evidence, but you should still continue to give physiotherapy because it is largely good for your body. And they recommend against the use of NSAIDs and opioids and pain blocks and muscle relaxants. So yes, that the evidence is a different story altogether, but our clinical experience are also important. When it comes to block, again, the literature is quite widely divided. Some say it works, some say it doesn't, but largely everybody says that walking tolerance may improve, but walking duration may not improve. So which Priyank sir rightly mentioned earlier, that neuritic component might help, but the duration will not improve. The claudication time will remain the same. Yeah. And the effectiveness and the duration for that effect also will be smaller. Perfect. I think you want to start your cases, Tausif?
So I would like to make one comment here that whenever I plan to give a block option to any of my patients, I always tell them the possibilities, what responses they can expect. So I always tell them that it's a very effective mode of treating your current acute condition. But about the responses, means it can give you very good result, but for how much time we really don't know. And there are instances, very few patients they complain that the block is not helping them. So that counseling has to be done well in advance, so that at least they are primed about what responses they can expect at the end of this treatment.
What medications do you use, Aditya, while giving the blocks?
Medications, okay. So I usually, it's a combination of triamcinolone, 40 milligram, 1 cc, and 0.25% Sensorcan, 1 cc. That is my main drug what I instill for SNRB.
Okay, anything different, Harshal? I know that you use a long-acting anesthetist. So what is the consensus? What is the best thing that you can do? Like, is there any difference?
So literature says only lignocaine is the best drug for the block. Lignocaine plus whatever steroid you want to use. But I have been practicing bupivacaine for a very long time, and my patients are happy. So as I said, my protocol is to also add bupivacaine. But I typically don't use it when there's a there's a major cardiac issues, or when I have to inject multiple levels. Then I would not add bupivacaine. But I've more often than not, I've also found there's some motor deficit, and then patient kind of remains there for half an hour or 1 hour, and that kind of thing. I always prime them earlier. That's why I don't have any major issues. But if you have not primed them, then it becomes a hassle for you for next couple of hours. Yeah.
And also in the block, and sometimes there is what we call as facet block. So it's not only the SNRB part. So if you feel that there is quite a bit of facet arthropathy also, which is the cause of the back pain, and basically that is more of a back pain for back pain, not for much of leg pain. But SNRB along with facet block also you can plan. If patient has both components significant, because there are means pain generators, the facetal capsule, which has got nerve supply. So you can numb them by giving that facet block. And that gives them very good pain relief as far as back pain is concerned. And along with that SNRB, where you are planning to target the root.
Okay.
Perfect.
Just for the sake of our delegates, I'm just putting up 2 disclaimers that we have not added revision surgeries here. We have not added degen scoliosis here, and we have not added listhesis here, fusions, because these are going to be the next topics. So a part of LCS which is associated with them will be taken care in the next couple of lectures. Yeah. Somebody asked something?
Very, very soon we are going to have a couple of cases which Dr. Tausif is going to present. Let's get everybody online, everybody who's there, because LCS is what we are going to deal with every day. So let's get everybody online and start planning how do we handle cases in real-time scenario. We know a lot of things that come in textbooks. We know whatever is said in literature. We have heard everything in the lecture halls. But what really happens in the clinic is what we are going to talk about now. So one after the other, Tausif is going to present the cases. And I would want each and every one of you to start telling what are you going to do next if the patient is sitting in front of you. How are you going to plan? It's okay. Anyone could do anything. Someone could do endoscopic, someone could do block, someone could do traction. It's totally fine. What you do till now, let's start discussing on that. And then we'll start putting some finesse in your treatment plan. So that at the end of an hour, we'll come out with a correct plan of managing a lumbar canal stenosis patient in your clinic.
Tausif, you can share your screen. Yeah.
Yeah. So before I share, just one quick question. What is the consensus of using a particulate steroid versus non-particulate steroid? To put it another way, what is consensus of using triamcinolone versus the depot preparations for steroid in the selective nerve root block?
So technically, if you look at literature, they say depot preparation is better than the particulate preparation, because in some people they can have reaction. Whereas there are some studies which say that particulate preparation is better than the depot preparation because it stays a lot more time around the root. Like I generally have seen the pain specialist give the particulate one. So basically triamcinolone, and I've just followed that. I've never actually used depot because patients are happy with triamcinolone. So we just go ahead with that. Anything different from your side, Harshal, Dr. Sheetal?
Both of them cause fibrosis, and if you're gonna contemplate a surgery, then don't give block. And
so that's actually a very important point. Now there is evidence also out there where when you operate a patient who have had repeated block, there is increased incidence of post-operative CSF leaks and wound complications. So if suppose you are actually going to operate on the patient, then refrain away from the blocks. And you could also counsel the patient that if you take multiple blocks, eventually surgery is going to be a problem.
One comment I want to make over here, the point we just now discussed about, in these patients, they induce fibrosis, means the epidural steroid. So if we operate such patients, or rather while doing surgery on patient who had taken epidural block earlier, in our experience, we have seen that there is thinning of dura also. I don't know whether it has got any literature support
No,
or
but
not.
evidence-based. It is evidence-based that there is an increased risk of
Exactly.
dural tears in patients who have taken multiple
Exactly.
blocks.
So the
There are a lot of
spontaneous
papers on that.
dural leaks also we have seen that in such patients there are spontaneous, means your Carrison punch is nowhere around that puncture site, and still suddenly there is one small pinpoint dural puncture has happened. So,
But there's
so
a
you have to be very
literature
careful.
against it also. So this is not a take-home message, but there's a literature
This is not a take-home
and also
message.
against
This is
it.
not
Yeah,
a take-home
yeah.
message. I'm just wanted to make one comment that you may not see also, but this is what we have seen intra-op.
Correct. That's a anecdotal evidence, personal experience. Yes, perfect.
Yeah. So I'll share my screen.
Sir, one more thing. What about PRP?
I personally do not have any experience of PRP, but Priyank, sir, you want to add something?
Yeah, so PRP, there is no evidence stating that it has any added advantage as over a selective nerve root block.
Okay, sir.
So I'll just share my screen. So is my screen visible?
Yes, visible. Please carry on.
Yeah.
Before that, Tausif, how many cases do we have?
We have 5 cases, sir.
5 cases, because it's 10, we have 30 minutes. So let's target 10 minutes per case, and let's stick to the plan and be very specific as to how we'll deal with the OPD.
Sir, one request, we also want to see the videos if possible for the operative procedures.
Yeah. So one is that we are going to have a full library set up for you of all the common procedures that we have discussed throughout the fellowship, and we'll put it up on the video. We have a 10-minute tips and trick video on laminectomy, a standard basic laminectomy, which at the end we'll play.
And I will send the link also to them once we have set up that library for all the basic cases.
Yeah. So before I start the cases, one short disclaimer basically. So as Dr. Priyank said, I am just going to present the case, and I'll just point out 1 or 2 delegates who can keep on discussing the case. So coming to the first case, this is case of 61-year-old male who has came to us with low back pain and bilateral lower limb pain. Leg pain is more as compared to the back pain, right-sided more than left side, and it is more below knee. He is also complaining of the claudication, which is he can walk for not more than 5 minutes. When I examined him, his gait is crouched. The back range of movement is free. Provocative tests are negative. On neurological examination, there is no motor sensory deficits. Reflexes are normal, and bilateral lower limb pulses are palpable. So, from this discussion, Nitin, am I missing something in the history or in the examination part? Hello, Nitin?
Yes, sir. Sir, I'm just thinking, sir.
Yeah. So, if you cannot, then Virendra can take over.
Yes, sir.
Virendra?
Yes, on the examination, the patient, how much claudication pain is after 5 minutes?
Yes, Yeah, claudication is
Bladder
5
and
minutes.
bladder bowel is not involved, neurologically intact.
Yeah. Bladder bowel is absolutely intact. So
And
still,
sensor,
I'm missing something on the
sensation.
history.
Good evening, sir.
Neuro is
So
intact.
basically, what Tosif is hinting over here is that we know what the history is, we know what the examination is, but there are few things we want to know if there is any important medical history that is there. So that is what he's hinting at.
Diabetes, blood pressure. Diabetes is mentioned or no? Is it a non-diabetic patient or no? Is an important question that should have been asked in the history.
Yeah, exactly. So going forward, like the two more history which are important here is the medical history and surgical history, because we know these are the elderly ones, and to come on the table, this much history is absolutely necessary. Our anesthetist guys are also like very well concerned about this. So this guy is hypertensive, diabetic, he has ISD, he has undergone CABG and some of the urethral procedures. So what next? Shashank, what next?
Now, in terms of investigation, if you ask me, then I would like to go ahead with the X-rays, dynamic X-rays, and then MRIs.
Yeah. So this is X-ray for you. What do you see in the X-ray?
I'll just want to come in here. Just want to know how many a time do you do X-ray first in a proper clinically diagnosed LCS and not the MRI first, just for the sake of it?
No, so this is a bunch of the investigations, and as our routine orthopedic teaching, X-ray should come first and MRI should come later. So that's way I have put in it. It is absolutely like
no. I'm just putting it across. I'm just perfect. Carry on.
Yeah. So it's just our routine orthopedic teaching. So that's why. So Shashank, what do you see in the X-ray?
So on the AP view, we can see scoliotic changes appearing in the upper lumbar region, and on the lateral we see some degenerative changes with not very significant disc space changes in the lumbar spine.
So you after this you mentioned
aortic calcification is also seen in the lateral X-ray. Calcification of aorta.
Absolutely spot on. So apart from anything that you can see of, Shashank, or should I jump to next what you
I think so. There is some listhetic changes at the L3. I think so. L543. Yeah, L2, L3 level.
Yeah.
We will have to go ahead with the dynamic change X-rays.
Yeah, and something which is called as vacuum sign, which is visible at the L2-3 level.
L2-3 level.
Yeah. So Kedar, this is Kedar. Are you here?
I'm here, sir. Hello. Yes.
Yeah. So so this is dynamic X-ray for you. What do you want to see on the dynamic views?
Sir, on the dynamic views, I'd like to see specifically in this case at L2-3 level, since the listhesis was noted at that level, whether there is any instability noted over there or no. On this X-ray film, there is some amount of instability is noted at that level. Also at other levels, but not a very significant or gross instability is noted.
Yeah. So like reading the hello. Yeah.
Yes.
Yeah. Kedar.
At L2-3 level, there is instability that is noted. Specifically at that one level, instability is noted.
Yeah. So Venkatesh, Dr. Venkatesh, this is the MRI picture for you. Can you comment on the MRI? Dr. Venkatesh, are you here?
Stenosis at 4-5 levels. There are other minimal stenosis seen on the above two levels, but I think the main culprit here should be 4-5.
Okay. Any other take on this? Dr. Gaurav is here. Dr. Gaurav, can you mute yourself and tell us what do you see on the MRIs?
Sir, according to me, both L2-3 and L4-5 are culprits over here. Both
Okay.
should be significant.
Anything on the axials? Some you want to comment on the axials?
The right side on 3-4 is also quite significant.
Yeah. I'll. Dr. Mustafa is also here. Can you come in, Dr. Mustafa, and tell us what extra you can see on the MRI?
The axials,
Dr.
I can
Mustafa?
see, if you look at the axials, we can see L2, L3 facet. There is some facet arthropathy at L2, 3.
Yeah.
Because you can see a lot of fluid of the facet. L2, L3 facet has a lot of fluid compared to the other facets.
Aditya
In
sir, would
Kaushik,
you
you
like
can go
to
ahead, yeah.
like conclude? Yeah. Would you like to conclude the MRI? Aditya sir?
Yeah,
Hello?
so there is very bad stenosis at L4-5 level, which is a maximum stenotic level with right side. I feel there is facet cyst rather than a disc. The facet has grown inside on the right side more. There is also stenotic component at L3-4 level as well. Okay, and there is early stenosis at L2-3, but I feel from L3 to L5, I would like to do. I feel there is stenosis from L3 to L5, and that's the reason maybe I would like. What is the patient's age?
61.
61, and leg pain is more than back pain.
Yeah, leg pain is more than back pain.
Okay, so I feel I would like to do decompression from L3 to L5 and maybe the undercut at L2 level in this particular case.
Okay, sir. So before that, like we should not miss the whole spine sequence to look for the above level like a higher level stenosis, and as correctly planned out by Aditya sir, the plan for this case. We'll quickly jump on to next case.
No, so Kaushik,
again, this
just one second. Let's ask everybody. Do you all agree with the plan? Is there anyone who would want to fix this patient, or do we only decompress? Do we have anyone, or everybody is okay to just decompress?
If it is not causing any back pain, then we will not. I don't think we need to fix.
Correct. So one is the clinical criteria. So if clinically the patient does not have back pain, then you would not want to fix. But now back pain is a very, very, very vague term. Like if you ask, every person in the world will complain of back pain, including this patient who said that there is back pain. So is there something that tells you, because this is a patient where 50% people would swear that they would want to fix because there's a degenerative scoliosis. You pointed out that there was vacuum in the disc. So all of these are pretty good, strong points for fixation. So why not fix? Harshal, would you not want to fix this patient?
I would love to fix this patient, but patient has so many comorbidities. Otherwise, I would have definitely done a fixation.
So if the patient does not have comorbid,
yeah,
so if
there's
no
significant.
comorbidities,
I would because of two things which I talked about earlier. They are kissing facets. If you see, I'm gonna go at the upper level, L2, 3, L3, 4 are two levels. You see, facets are very close by. Secondly, there's a significant sagittal angulation of the facet. If I want to do a good lateral distal decompression, I will be violating both the both the articular processes. I would tend to fuse it because he's a 60-year-old, and 60 for me is still young if his demands are as much. But if he's kind of a laid back, heavy kind of a guy who's not having a lot of demands, then I might not. But in this case, I think because of the lateral listhesis, vacuum sign present, there's a retrolisthesis, developing degen scoli. I might think these points go in favor for me for fixation. Yes, I'm just trying to be a devil's advocate here. Yeah.
Harshal,
Gives a
Well,
different
so
perspective.
we
Yeah.
have Harshal over here who would want to fix the patient if the anesthetist want us to do it. If Aditya told us that we'll just do a decompression from 3 to 5 with undercutting at 2, 3. Uh, is this the only two treatment? Anyone would want to do an endoscopic decompression over here? Is laminectomy mandatory? Do we do tubular decompression? Do we have anyone in the house who does endoscopic surgeries or would want to do an endoscopic decompression over here?
Any takers for endoscopy?
So, Harshal, we have a question for you. Like, if you want to fix, what levels would you fix?
Yeah. So again, I'll go L2 to L5.
Fair. So basically, see, this case here is for one thing that whenever you get a patient, there are so many different factors that you have to think about when you have to take a decision. So clinically, back pain is an important indicator towards fixation or no fixation. Just a dull aching back pain is not important. You should look at two different things. One, you should look at how they bend forward and then they come back. So if you see a patient who is having a smooth transition when they bend forward and then they come back, that is called as a stable spine. But when you see that a patient is bending forward and then when they come back, they are coming back with an extension catch, which means they have to support their back when they are getting up. That's one point towards clinical fusion. The next part is you should see how the patient is sitting. Like if a patient is comfortably able to sit on your examination table cross-legged without any major back pain, that means the lumbar spine is stable enough. But if you see that the patient is having difficulty in sitting cross-legged and is having a lot of pain, that is going to hint towards a clinical category of fusion. That's one bit. Then comes the X-rays. Now in X-rays, you have got one static X-ray over here, which is a AP X-ray of the spine. And then you have a lateral flexion extension X-ray. So when there is overt instability on flexion extension, and when so that is the time you would want to fix. Versus there are few special X-rays that you can do in degenerative scoliosis. We just brought this up, but we are not going to discuss this point further because we are going to have a separate talk only on degenerative scoliosis. So in that you would know how to decide which level to fix. Are you going to do a limited fusion or are you going to do a full segment fusion? Are you going to do just a lumbar fusion or are you going to do a dorso-pelvic fixation? Are you going to look at parameters to correct the lumbar lordosis? All these are points to think about for our next talk on degenerative scoliosis. Now here, clinically, the patient does not have a lot of back pain. Clinically, they are not hinting towards fusion. We have patients with a lot of comorbidities, so you don't have a lot of anesthesia time. So you have now decided that you want to do decompression. Now, decompression levels. Remember, you were talking about how to pick the levels. Tosif, let's have the actual cuts here. So, guys, how do you decide which levels to fuse? So, start going from down above and see the actual cut at L5S1. Don't see any other levels. Just see L5S1. Would you guys want to decompress L5S1? Not really. It looks like a pretty normal level. If this comes in front of you, you don't want to do anything. So get that out of your decompression level. Now see the axial cut at 4-5. 4-5, there is significant stenosis. You see that there is some crowding on the right side, which means it's either a right-sided fasciitis or a right-sided disc. Remember that in mind because when you're doing the surgery, you want to specifically explore this right-sided route because you're going to find something different than the left side. So that level requires to be decompressed. Let's go to the upper level, L3-4. So L3-4, do you see that there is any stenosis? Yes, there is stenosis. Would you operate this patient if this patient came with only this stenosis? Yes, you would operate. So this should be in your decompression level. So now you have two levels which you want to decompress. There is level 3-4 and there is level 4-5. Now let's go to 2-3 level. 2-3 level, would you want to decompress? Not so much because it does not look that stenotic. There's mild stenosis. If this patient comes to me only with this thing in the MRI, we would definitely not operate. So this is the level where there is borderline question that you want to decompress or not. In this situation, we do something called as undercutting. Now, what undercutting basically means, the major part of your stenosis is going to be because of your ligamentum flavum. So if you're doing a L3 to L5 decompression, you are supposed to remove the entire L4 lamina. The L5 lamina completely need not remove, because when you remove the L4 lamina, you will remove one attachment of the L4 ligamentum flavum. The other part is attached to the L5. And if you don't want to decompress L5S1, you don't touch the L5 lamina, because the L5S1 ligamentum flavum you don't want to disturb. So here you have to make a dome of your L5. So your L5 level is completely decompressed. L3-4 anyways you want to decompress, so you are going to remove part of your L3. But since you don't want to completely, like you just want to remove part of the L2-3, you do something called as undercutting, wherein you remove the entire L3 lamina. But L2-3, you don't remove a lot of bone. The only thing that you remove is the L2-3 ligamentum flavum, and that is what is meant by undercutting the L2. So that is how we select the levels, and that is how we decide how much we have to decompress. So this is once you have decided that you're going to decompress, and once you decompress, you do this. Dr. Harjot mentioned a very important point, that you are seeing kissing facets over here. So when there are kissing facets and you're doing decompression, there is a chance that you're going to knock out the facet joint, and that could create potential instability. So a lot of places you hear that intraop you are taking that decision that you want to fuse that area, but I will strongly recommend against it. All the planning has to be a pre-operative planning. Once you have planned the patient pre-operatively, then intraop you just execute your plan. Don't change your plan intraop. Don't constantly keep thinking that have you created instability. If you were thinking that there is going to be instability, it has to be a pre-op decision and you do a intraop fusion. But never you should change your plan intraop. So like Aditya mentioned, the plan here is going to be a L3 to L5 decompression with 2-3 level undercutting, which means you just remove the 2-3 ligament, but don't disturb the L1, L2 ligament area.
There is question in chat box that since Harshal said fusion has to be done, so is there any chance of adjacent segment disease? I think that issue is going to be there always, theoretically.
Like if the question is just about adjacent segment degeneration, the answer is yes. Always and always whenever you use a patient, there will be a adjacent segment degeneration. 10% of patients with a fusion will develop clinical adjacent segment degeneration, and 50% of these patients eventually will require a extension of fusion. So that's generally the concept about adjacent segment degeneration. But whenever you fuse, you are always going to have an adjacent segment degeneration. Clinical or not, it's a different case altogether.
And the question of that question only was how to prevent that. So my take on that is while doing your dissection, you have to be careful while using your cautery, because if you are using your cautery and means unnecessarily, if you just damage your proximal most facet, then you may end up with adjacent segment disease. Or the connecting rod. The connecting rod has to be appropriate length. It should not be too long, so that it's not causing impingement on the facet above your last or rather the proximal most fusion level. So these are a few points where you can take precautions to prevent any adjacent segment disease. Any other additional points, Priyank, Harshal?
Yeah, but it's a big, but I think you've put it well right now. Let's not discuss further on this, because this is going to be a long discussion.
Yes,
we finish the LCS right now.
Yeah.
So I'll just jump on to the next case. Hello.
Quick, Tausif, quick. Yeah, you give up a brief history and examination and get the images. Yeah.
Yeah. So this is 71-year-old male who has came to us with low back pain and right leg pain, more of the below knee type. Again, leg pain is more than back pain, and claudication is for 5 to 10 minutes. On examination, he is crouched, back range of movement is free, provocative tests are negative, neurologically he is intact, there is no hyperreflexia, pulses are palpable. Medically and surgically, he has undergone only cataract surgery, and these are the x-rays for him. For the short of time, I'll just jump on to the MRI. So this is MRI to him. So Dr. Shweta, can you, Dr. Shweta? Hello?
No, she'll not be able to answer. I think Aditya Kasture, you are there. You should take up.
Yeah, so Dr. Aditya Kasture will take the question. So Dr. Aditya, can you read MRI
Yes,
for
sir.
us?
Yeah. Yes, sir. This looks like a lumbar canal stenosis, sir.
Yeah.
The central canal
Can you
stenosis.
brief more?
So multiple level disease degeneration with central lumbar canal stenosis, sir.
Facet cyst, L45.
Dr. Vaishak is here. Can you take this question and can you read MRI for us, Dr. Vaishak?
Yes, sir. There is something in it's multi-level LDDD with something at L4, L5 level, looking like some cyst in the cord, near the cord.
So,
yeah, very good.
Cyst near pleural sac.
Can you zoom into that image? Is it possible for you to do that?
Yeah. So,
so he's got it right. There is multi-level stenosis, but at 4-5 there is some cystic thing on the around the cord. What do you think it is?
I think it looks like a facet cyst, not a facet cyst. Sorry, a tarlos or something. It's beyond ligament flavum. It's inside the cord.
Fair. So here we are not very sure. What are the commonest things that you feel that can be here?
A tarlos cyst.
What is a tarlos cyst? Tosif, you want to tell?
So tarlos cyst is most of the time it is a retention cyst basically, and it is more in the sacral area rather than in the lumbar area.
Correct. So almost always these are retention, CSF retention cyst, and almost always they don't require any kind of treatment because they are beyond the central canal. They are either intraosseous or they are in the paraspinal areas. The here you are seeing a cystic lesion in the dural space next to the facet joint. So the two differential diagnoses are either it could be a facet cyst or it could be an arachnoid cyst. All right. So is this important that what we have identified on the MRI? Does that kind of influence our clinical judgment or our clinical plan?
Yes, sir, definitely.
How does it?
We can change the operative course from decompression to epidural can be tried, sir.
No, so right now we are already clear that we are going to do the surgery for this patient. And in surgery, is the plan going to change in any way? How will it change?
Decompression should be done very carefully.
Fair. But why carefully? What do you anticipate if there's a problem? What problems do you anticipate during decompressions?
There can be leaks, a dural leak. Because,
okay, so CSF leak is something that you can expect if it's an arachnoid cyst. Harshal, would your plan change because you have found a cyst?
Yes, definitely. I just want to kind of, Tausif, I'll stop your share and I'll add my screen share for a minute. Yeah. Just want to show because of the current scenario, I'll just put this up for you guys that you understand what I mean to say. Can you see my screen? So typically decision of fusion in a stable spine
is a very tricky thing. And here on the X-rays, you could not see any major instability. But when to fuse a stable spine when you're actually attempting to decompress? So always look at the facet, look at the facet tropism, look at the facet arthropathy, look at the facet fullness, and look at the facet cysts. The other subtle signs of instability are Bastrup's lesion, revision or recurrent disc. Sometimes I tend to fuse. Significant modic changes and vacuum signs intradiscally. These are one of the determinants for me to think of planning a fusion. The other determinant, as we have already discussed, age, expectations, lifestyles, comorbidities, clinical presentations, and the need or want of a wider decompression or a facetal violations. So I would just want to put this, I just wanted to put this across that in a stable spine, when to think of fusion when you're planning a decompressive surgery. I think I'll stop my share.
Yeah, those are very important points, Harshal, that you just mentioned. So these are those cases where you could err towards fusion if you identify these. There was one question. So coming back to our thing, Sheetal sir, are you still with us?
Very much, yes, still. Yeah.
Sir, how often do you feel that if there is a facet cyst, that means there's definitely an instability and you'd want to fuse? Does that influence your decision, or it's not really that important?
No, so as we have mentioned all through, we still rely a lot on clinical grounds. So if there's only major symptoms, facet seems to be quite coronal. Also, as what Harshal said, so maybe only decompression would work in this scenario. But there are now recent reports in which the literature is more in favor of fixing situations in which there are facet cysts. The argument being that if you fix up an arthritic area, arthritic segment, then the chances of recurrences are lesser, and you have blocked that segment. So again, recurrence stability is taken care of at one go itself. So in this scenario, it's a bad option to think of that with the recent literature coming in.
Correct. So whenever you see a facet cyst on an MRI, you could give 1 point towards erring towards a fusion, but it's not at all a rule that facet cyst absolutely equals to fusion. There are a lot of literature out there showing good results of only decompression with a patient with facet cyst. But when you see this type of picture, you should keep in mind that there could be an arachnoid cyst. So intra-op rupturing the cyst is important, and the patients do benefit a lot. And you could see CSF intra-op when you're rupturing the cyst. So that's important. Tausif, let's go next. Unless I think Harshal, you have something to show.
Sorry. Yeah. I just wanted to show this one funny, good literature actually. These are the trends in last 2 decades basically. 2000 up to 10 to 14 and 16 to 19. And we have had a wonderful literature come across that when you should not stabilize.
Harshal, sorry to interrupt. Delegates are asking about full screen. Just make it enlarged, that slide.
Just a minute. I was going to show one slide only. That's why I was doing this. Yeah. I think full screen is happening right now. Yeah. Right. So if you see, we have had wonderful literature available in the available across, which has done RCTs and significant meta-analysis. And they said in a stable spine, do a minimum decompression only. Don't do a aggressive unless and until there are some certain signs which we discussed earlier, when to fuse or when to think of fusion. But largely, even after coming these RCTs and everything, the trend is always towards fusion. So if you see, this is a very good literature, and that's a trend that has been developing. And I would want an opinion from, I think, Sheetal sir, who has seen the growth of spine surgery in last couple of decades. So, sir, what do you feel? Why more fusions nowadays?
I think so now it will be very difficult to say why more fusions. But we are seeing, but at the same time, equally good results with decompressions only have been seen. At the same time, we are seeing the other side also now. The more and more fusions we are doing, we are seeing more and more adjacent segment problems. So we do not know which way we are going, but the earlier generation has seen a lot of only decompressions with good results, but maybe extensive decompressions there had led to instabilities and other finer detail asset orientations and not doing regular stress views. All these things could be the reason that you were getting earlier a lot of failed backs, which prompted us to get into fusions and fixations. And now that we are doing more and more studies on facet orientations, detecting instabilities pre-op, and then we are going more towards fusions. But then again, we are having one more problem for adjacent disease problems. So I think so. This will be a very complicated to discuss eventually to get to a single message at this discussion. But yes, fixed fusions, I'm sure they are on the rise.
Yes, sir. Yes, sir. Yes, sir. And I would just want to put it across. I'll stop my share, but I just want to ask Dr. Priyank, how much of an importance does he give for sagittal balance when he plans decompressive surgeries in such cases?
Decompression or fusion? Harshal, your thing is mute. No, sagittal balance in fusion or decompression?
In a lumbar canal stenosis in an elderly gentleman, 65, 70-year-old, there's a sagittal imbalance, and how much of your decision making tends towards fusion when there's a sagittal imbalance?
No, so one is I'm very clear about the fact that the decision about fusion majorly depends upon the clinical, the history and the clinical presentation rather than the radiology. And sagittal balance practically comes into picture only when we are talking about surgery for a degenerative scoliosis. But in a plain lumbar degen where we are doing short segment fusions, I personally don't look a lot towards sagittal balance. It's more important when you're correcting deformities in the spine.
Perfect. Yeah.
So coming to the fact that, so here, because there's a facet cyst, you could err towards a fusion. That's that discussion that happened regarding this case. Do we have?
Yes, sir.
We take a couple more cases, or we go for the video right now? I think one more case, Tausif, that's important. Next case.
Yeah. So, so just for the benefit of audience, this is what we have excised, which is a facet cyst in the operation theater. So, so I'll take this case. He's a 83-year-old gentleman. He has complaining of bilateral lower limb pain, right more than left, and low back pain. Claudication is for 2 minutes. On examination, he is unsteady. Toe walking is difficult. Range of movement is free. Provocative test is negative. Neurologically, he is sensory and motor intact. And bowel bladder is intact. So, Dr. Sankram, am I missing something?
Hello? Yes, general well-being, like a history of diabetes and other health conditions.
Yeah, so here it comes. He is hypertensive, asthmatic. He has BPH, and he has underwent hernia surgery.
Okay.
Anything more I'm missing out? Hello?
Yes, sir. Yes. I'm just thinking.
Yeah. So, Dr. Nishant, if you are here, can you take this question?
Yes, sir. In any case of LCS, I would like to check the distal pulses as well. Vascular system needs to be checked, sir.
Yeah. So bilateral lower limb pulsations are like well felt. Still, I'm missing something.
Just rephrase your question. Guys, what do you feel the diagnosis in your on the symptomatology? Only on symptomatology, what is the diagnosis?
Be a lumbar canal stenosis.
Perfect. On examination, do you feel that things are matching?
Unsteady, very clearly.
Extra pyramidal signs or UMN
Very good.
signs.
Venkatesh has pointed out rightly that there is something gadbad in the gait. There is an unsteady gait.
Unsteady gait is not explained.
Yeah, so that is something that you have to look at.
Cervical spine evaluation to be done.
So what is that? If I tell you one single test that will tell you if that the patient has got a myelopathy or not, can you please tell it?
Flipping of footwear.
Reflex should be tried.
Sorry?
Hoffman's.
No.
Flipping of footwear.
Hoffman's is good because it's a UMN sign specific to upper limb. What if there's a dorsal myelopathy then?
Tandem test, tandem walking.
Babinski's sign needs to be checked.
So Babinski is positive. How do you know if there is a myelopathy versus a lumbar canal stenosis? So there is, if a patient has heel shin, Venkatesh, can you tell me what do you mean by heel shin?
So for coordination and even the heel shin test, sir.
Okay. See, basically, the patient is in your cabin. You have got a history. You have got claudication. You have got unsteadiness of gait. When you check the patient, if the patient has got Babinski positive, but the knee jerks are, yeah, exactly. Gaurav has pointed it out right. Tell me what will you find in a pure LCS versus a LCS with a tandem stenosis? In a pure LCS,
presentation of
the
motor neuron and lower motor neuron
are going to be muted. Whereas in a tandem stenosis, you will find that the knee jerk is brisk and the ankle jerk is muted. So if you find in a LCS patient the knee jerk is brisk, then you have to start thinking that the patient has got tandem stenosis.
Yeah. So
yeah, Kaushik, can we have the MRI over here?
Yeah. So as Dr. Priyank correctly mentioned, like reflexes were brisk, and on like detailed history, he was complaining of imbalance of the in the walking and fine motor dysfunctions of the hand. So this is MRI for you. So this is the lumbar one and whole spine screen. I have put it on. Just retrospectively, if I haven't seen the whole spine screening, then I will be completely blinded for the cervical spine, and I would end up doing the lumbar spine only and not the cervical spine. So since I have screened cervical spine, and since patient was having the upper motor neuron symptoms, we have the cervical spine MRI too. So Dr. Balaji, can you comment on the cervical spine MRI now? Dr. Balaji. Hello. Hello.
Yeah, no problem. You're audible. Anyone want to take this up? Nishant was there, I think. Nishant, you want to take this up?
Multiple indentations over the cervical spine from the level C3, 4, 4, 5, 5, 6.
Perfect.
Anything? And in the axial also we can see the disc protruding
But
out.
what Tausif's cursor is pointing towards?
There is an overlap, sir.
Changes. Myelomalacic changes.
Myelomalacic changes.
Exactly. Okay. So MRI showed the myelomalacic changes. So for the short of the time, just in such cases, how many would like to get a neurologist involved in such cases? Hello.
So I think what is the dilemma here? You have a proof that there's an involvement of the lumbar spine. There's a severe LCS which is symptomatic. There's also proof that on radiological proof that there's a cervical compression, myelomalacia changes, and which is symptomatic. He's having unsteady gait and reflexes, I think hyperreflexic and all. So yes, how many would tend to get a neurologist involved?
So just adding one point in this, I think Tausif mentioned about patient is not able to walk on toes. Am I right, Tausif, in this case?
Yeah. Yeah.
So there is S1 deficit. So
Yes.
there are chances that unsteady gait might be because of S1 deficit, because S1 is one of the root values for your hip abductors as well. So,
Okay, but we have
no,
three, four
I'm
conclusive
just
proof. Yeah.
trying to
True.
I'm just putting this thought in
Point across.
delegates'
Yeah.
mind that
Yeah.
S1 deficit is there plus cervical compression. So what is the causative factor?
Yeah. Perfect. So this is actually pointing towards a case of tandem stenosis when you have multiple compressions in the spine, and then making a decision. So it's a decision-related dilemma that what should be treated first, what should be given priority, are they to be treated together, or do you need another expert opinion to point you towards that decision making? So Tausif, you can actually take a lead and start. Yeah, tell me what you did.
Yeah, so since he has both the symptoms, like upper motor neuron symptoms and as well as lumbar canal stenosis, we straight away went and we have planned the tandem decompression, that is the cervical and the lumbar at the same time. So hello.
Perfect. Got it. Okay.
Yeah.
So what was your rationale when patient came to you with just low back symptoms and leg pain? How did you counsel them for a tandem surgery? 2 surgeries at one time. He said, boss, मेरे को तो upper limb में कुछ था ही नहीं.
Yeah. So basically, again, it is a clinical problem at every clinic. Patient usually comes with the lower limb symptoms, and we are saying that we are doing 2 surgeries, one in the neck and one in the in the lower back. So in our day-to-day scenarios, we counsel the patient that cervical and the lumbar per se, the cervical is more important as compared to lumbar spine. But at the same time, since you have jumping reflexes, it indicates that there is involvement of cervical spine, and we should do the cervical as well as lumbar.
Perfect. So just want to divert it a little bit more, that it was actually a symptomatic cervical and symptomatic lumbar. But what if, Dr. Sheetal Mohite sir, if it was a symptomatic lumbar but a symptomatic severe cervical compression, what would be your plan? Asymptomatic patient has no symptoms at all, no sign, just my reflexes maybe.
No, so in these cases, as we have been doing all this while, we usually involve a neurologist in. Okay. And a neurologist opinion is very, very valid in our cases. One is that. Secondly, we also, if the condition is not so bad, but there is mild indentation, but no myeloma, no cord swelling, nothing of those sorts, then we do SSCPs. If the SSCPs show that the SSCPs are not delayed, then valid enough to not touch it, but at the same time take good care while positioning and everything else. And you can leave it at that go and keep it as educate the patient about sign symptoms, and if any worsening, then at that stage you could call for that.
Okay, but do you prefer a tandem surgery?
Opinion.
Yeah. You do prefer a tandem surgery, but if patient is not,
I do prefer. Yeah.
Yes. How many in the delegates would do a stage if there's both symptomatic? How many of them would do a stage surgery? Anyone want to take it up? Someone for stage surgery?
Yes, sir. First, we'll go for cervical decompression, following which, looking at the symptoms, how is improving, because if at all he is into myelopathy, improvement would be stagnant in that phase. So even if you do a lumbar decompression, I don't think it's going to be of much use to the patient.
Okay. Now I'm talking about 2 things: cervical first versus both together.
So generally, the rule is that if there is a symptomatic cervical and symptomatic lumbar, the cervical has to be before the lumbar, because as soon as you do a lumbar decompression in a symptomatic cervical, post decompression, the myelopathic signs will become overtly positive. So someone who's initially walking with a claudication will start walking with a spastic gait. So just a quick summary about why this this case had come up is that remember that each and every patient with lumbar canal stenosis has a possibility of a tandem stenosis. So don't operate lumbar canal stenosis without doing a whole spine screening MRI. In India, it is definitely justified because the incidence of tandem stenosis is more in the Indian population than the Western population. Because of the geographics, the genetics, and the increased incidence in OLF and OPLS. When we start deciding where we want to do surgery, if the patient is fit and the patient has both cervical and lumbar clinical stenosis, like you see the signs and symptoms, then err towards the tandem stenosis. If suppose you have to do one after the other, do cervical first, followed by the lumbar. If suppose there is a scenario where you have a cervical stenosis, but it is a radiological stenosis with no clinical signs or symptoms, then you can do lumbar by taking all the due precautions which Dr. Sheetal Mohite mentioned. So that's a little bit about tandem stenosis that you all should be aware about.
I'll just add one more point, and then I think we should wrap this topic. That recently I had a case we operated together. Dr. Priyank was also there. Patient was having ekdam tight cervical, symptomatic lumbar, and we had counseled him for a tandem surgery, but he's absolutely not willing. No, I don't want to do 2 surgeries. And then what we did was we did it under neuro monitoring. We told him that if anytime we find a decompensation during positioning, during surgery, anytime, we might go and do a cervical at the same time. But if everything goes all right, we'll do only lumbar. The only reason was he was asymptomatic. He was properly counseled, and all the due precautions were taken as Dr. Mohit and Dr. Priyank mentioned earlier.
Point taken, Harsh.
So great. So that's all about lumbar canal stenosis. A quick summary: lumbar canal stenosis is more of a clinical diagnosis than a radiological diagnosis. When a patient has had lumbar canal stenosis, remember you want to rule out all other conditions which can present like that. So specifically, you want to rule out vascular and you want to rule out severe peripheral neuropathy. When you are taking up a patient for treating lumbar canal stenosis, the treatment is surgical, but it can be very well managed by a closed observation and close observation, some rehab, some lifestyle changes. Wherever needed, if there is acute exacerbation of pain, you can on a case-based scenario use selective nerve root blocks. But when you have decided that you want to treat lumbar canal stenosis, the treatment is surgery. Then the decision comes that do we do decompression alone or do we do decompression and stabilization? Again, those points which Dr. Harshal had mentioned are important points in simple lumbar canal stenosis where you would err towards fusion. A lot is dependent upon the clinical symptoms, where back pain is more. There is clinical instability on moving the back, or there are telltale signs on the X-rays which show that there is going to be a you are preempting an instability. When you are decompressing when you are planning the surgery, the levels of decompression should be decided like how we decided, and then you have to execute the surgery. There are different types of surgery that comes for lumbar canal stenosis. You have plain laminectomy, you have got microscope assisted laminectomy, you have got interlaminar decompressions, you have got tubular decompressions, you have got endoscopic decompressions, you have got different approaches like spinous process sparing approach. So there are so many different types of surgeries that are described for lumbar canal stenosis, but the gold standard remains laminectomy. Depending upon the levels, depending upon the age, depending upon the time under general anesthesia, you can decide between and depending upon your infrastructure, you can decide between the different types of cases. Remember, older the patient, longer the segment of decompression, err towards open quick laminectomy decompressions. Younger the patients, limited the levels of decompression, or towards minimal procedures like endoscopic decompressions, tubular decompressions. Remember, the key to a good outcome is taking all the different factors into hand, and a 80-year-old will not benefit by doing a multiple level endoscopic decompressions where you have put the patient under anesthesia for 6 hours, whereas a young 18-year-old guy does not really require a long segment open decompression when a endoscopic procedure is available. So with this, you have to decide how to identify and treat patients with lumbar canal stenosis. It's like a quick summary of the entire talk and entire thing that has been conducted today. Any questions specific to this? Harshal, Aditya, Tausif, Sheetal sir, you guys want to add anything more than what I just said?
I think not technically, but I would just say this, that I think I would encourage now, because we were also a little this thing on the group, but now I think everybody should add some cases, and it will be a case-based discussion would be better, because this is a limited time. But you guys can actually put up some cases which you want to start discussing, and all the faculty would be very happy to contribute. And because LCS is an unending discussion, we can go on for another couple of hours, and there's so many different scenarios. LCS with ONE, what to do first, floating LCS one level here, then 3 normal levels and 1 level above. There's so many other things which we can actually discuss, and I think you guys can add some cases. We'll also try to put up some cases and initiate a discussion. Yeah.
There's a question on the chat regarding canal diameter, which they mention on the MRI. So there is no clinical significance of the figure or the number that is mentioned on the report. You could have a small canal diameter where nothing needs to be done, and you might have a wide canal diameter with a significant foraminal stenosis requiring surgery. So those are of no value. Don't bother about them.
So as I mentioned on my talk, that the radiological definition of LCS is of academic and research value, and I don't think it has any significance.
Like practically, maybe it actually could help in convincing the patient that the patient has a problem, but medically, there's no rule.
I think Priyank has
saying something. Yeah. Please.
I think Priyank has summarized the session very well. Just wanted to add one comment that keep your mind open. Don't have fixed ideas or thumb rules that 1 + 1 2. It can be 3 also in case of treatment. Okay. Yeah. So be flexible with your plans. Judge or plan your whether it's conservative pain blocks or operative treatment as per case-to-case basis, as per the clinical scenario and radiological scenario. So keep your mind open. That is the key.
Harshal, if it's okay, I'll start that 10-minute video on laminectomy, and then we end the session.
Yes, sir. Yes, sir.
Yeah,
and then we
yes,
ask Dr. Aditya in the end to give a next lecture just a brief.
Sure.
And yes, yeah.
Sure. So I'll quickly share that screen.
So till the time Priyank is loading.
Can you see this? Are you able to see?
Yes.
Okay.
Yes.
Good morning, everyone. I'm Dr. Priyank Patel, and I'll be speaking to you on laminectomy. Laminectomy is a procedure which every spine surgeon should master. In fact, it's the first surgery which every surgeon is taught during their fellowship. So let's get to it. Preoperatively, make sure that you use all the imaging modalities that you have at hand to plan the exact extent of decompression. This will make your surgery very specific, quick, and atraumatic, thereby avoiding the treasure hunt syndrome. In positioning, remember that you have a good head support along with the Ryle's tube, which is passed. You can use a foam head support, or you can use attachments to tables with tongs, or some newer jelly head supports. Make sure that whatever you use, you have adequate and good eye padding. Keep the abdomen free from the table with the help of bolsters. These bolsters can be arranged either horizontally or vertically. You have newer generation tables that are available, like the Jackson frame, which has got multi-point fixation and the abdomen is completely free. Remember, when you're positioning the patient, The arm should not be abducted. This causes traction to the ulnar nerve, and sometimes you can land up with ulnar nerve palsy. Once you have positioned the patient, you mark the area which you want to decompress with the help of a needle. Confirm this under a C-arm. Some people prefer to infiltrate with the help of some vasopressor diluted in saline, and it can be done pre-surgery. Some people post-surgery before closure infiltrate in order to give a good analgesia. The advantages are it decreases the bleeding during exposure, and it also helps delineate the tissue planes. But some disadvantages are that if your surgery is prolonged, eventually the bleeders open up later, and in some cases it could cause some skin problems. Once you are ready with all this, you can take your incision. The approach to laminectomy is a posterior approach to the lumbar spine, where a central midline incision is taken. Once incised, you start taking off the paraspinal muscles from the spinous process. Try to remain subperiosteal and not enter the muscular planes in order to avoid unnecessary bleeding. So here you can see that the patient has been positioned and the incision has been taken. You see how we are using a periosteum and slowly, with the help of a cautery, separating out the muscles very close to the bone. So we are trying not to get into the intramuscular plane and cause unnecessary bleeding. The ideal amount of dissection is till you can identify the bars on either side. You can use a simple rubber catheter to prevent any damage to the skin by covering the cautery tips. So dissect laterally, keeping the pars as the outer limit and not damaging the capsule. This is a very important point. Once it's done, you start removing the spinous process and then thin down the lamina to make decompression more gentle. So after an adequate exposure, here what we are trying to do is identify the last mobile segment. So whenever you are doing a decompression right up to the sacrum, you know that L5S1 should be your last mobile segment, and this helps you confirm your level. In a smaller incision or where you're not going up to the sacrum, you can use a C-arm to confirm your level at this stage. Once your level is confirmed, you start removing the interspinous ligament with the help of a knife and nibbler. The next is you take a spine cutting and start removing the spinous process. You can use a nibbler to clear out the remaining part of the base of the spinous process and any soft tissue which is around. Once that is done, use a cautery to clear out all the soft tissue and delineate the bony landmarks. Try not to burn the facet capsule. And after that, you can start thinning off the lamina with the help of a nibbler or the help of a burr. This makes decompression easy later on as the efforts with the forward reduces. Use ample amount of bone wax to seal off all the bleeding edges. Then you can start taking a ronger. Usually you start off with a number 3 or a number 4 ronger. In tight stenosis, try sticking to number 3, whereas in moderate stenosis, you can take a number 4. Start taking off the lamina bit by bit, making sure that you don't end up biting the dural sac, which is just underneath that. When using the kerrison, it is very important that you have a good grip and good control over your instrument. So your left hand should be holding the kerrison and should be placed on the patient so that you have a good control over your instrument. As you move further with your decompression, you can start packing cottonoids under your lamina to safeguard the dura underneath that and to start slowly separating off the ligamentum flavum from the lamina. So the cottonoids or patties help create a smooth plane under which you can start passing your forwards. Slowly and steadily progress along and start removing the remaining part of the lamina. The suction is one another tool that can sometimes cause dural injuries, especially if the end is rough. So you can cover it with the help of an Indian rubber catheter and prevent dural injuries because of that. A Penfield or a dura retractor also helps creating plane in between the lamina and the dura. Make sure that the surgical site is free of any blood so that you can visualize what you are taking. Watch out for innocuous looking fibrous strands between the dura and the ligamentum flavum. Don't be in a rush to identify the flavum and pull it out, because sometimes there are strands which can take a chunk of dural sleeve along with it and causing unnecessary dural injuries. So you can see here how we are slowly teasing out the ligamentum flavum. You can use cottonoids or pen fields at this stage to help create a plane between the ligamentum flavum and the dura. You can also use a disc forceps or a nibbler to separate out all the ligamentum flavum from the dura. Make sure that there are no adhesions, and if there are any, use stitches to separate it out before you pull them out. So laminectomy is not the surgery, it's just the approach. What you want to do here is you want to decompress the spine. So in order to decompress the spine, you have to remove the central compressing element, and also you have to remove the elements which are compressing the lateral recesses. So in case of laminectomy, what you do is you just remove the central lamina, but the lateral recesses are not decompressed. If you want a good decompression, you have to remove a part of your medial facet which is hypertrophied and is pressing on the exiting nerve roots. So this will complete your decompression. So here you can see a good central laminectomy is done, and I'm using a dura retractor to make planes between the dura and the hypertrophied ligamentum flavum and the hypertrophied medial facets. Once I make a good plane, I'll use a forward and clear out soft tissues that is overhanging on the dura. By doing this, I can get a clear visualization of the hypertrophied medial facet. And then with the help of a pen field retractor, we are separating off the dura and making sure there are no adhesions. Patties are put underneath the facet joints so that there is no injury to the nerve roots when we are doing the facetectomy. Now, there are different ways by which you can do facetectomy. We use osteotomes to take off that hypertrophied facet, but you could very well use a ronger in this place. Make sure that the patties are well underneath the facet joint so that if your osteotome slips, it does not cause a root injury. Once that's done, the loose fragments of the hypertrophied facets are taken off with the help of a kerrison. There could be sudden increase in bleeding as the epidural space starts getting decompressed, or you catch or you tear a epidural bleeder. So make sure that you have a good assistant with a suction in his hand, and don't put a forward in the epidural in the lateral recess without a good visualization of the root. Otherwise, you might catch the root while trying to remove the hypertrophied facets. You do this till you have a good visualization of the root. So if you have done a good facetectomy, you will be able to identify the root underneath the parts exiting to the foramen. Once adequacy of decompression is checked, the area is then packed with the help of patties, and the facetectomy of the other side is done to get a good bilateral thorough lumbar decompression. Once the adequacy of decompression is checked, the lateral recess is then packed with the help of strips of cut gel foams, which help control the epidural bleeders. And then the skin is closed over a drain in multiple layers. So that's all about laminectomy. Thank you and have a nice day.
I think it was a great illustration of a procedure laminectomy, I think, which you said in the beginning, that every spine surgeon should be mastering that technique. Any questions from the delegates? Any questions on the topic, today's topic? I think we'll be able to answer now. Perfect. Dr. Aditya, you want to conclude and give a timeline for the next lecture?
Okay. Next week, we are going to have a session on TB spine. And most probably we'll be having that session on Wednesday night. We will confirm the exact day in a day or two. For today's session on LCS, it was a great show by Dr. Harshal and very well supported by Dr. Priyank Patel, Dr. Sheetal Mohite, and all delegates who participated actively in this. And last but not the least, OrthoTV, we would like to thank OrthoTV for continuous support in this venture with VR Spine. So hope to see you guys in next 2-3 days, most probably on Wednesdays for our TB Spine session. Thank you.
Thank you.
Good night, guys.
Yes, thank you, and India won.
Thank you, guys. Thank you.
Thank you,
Bye-bye.
Thank you. Bye. Bye.